Hi there, my name is Jose Canas and I worked for Preventure Health Services, and back in 2008, 2009 we were actually looking at an opportunity to have one of these automated dispensing machines, or automated dispensing cabinets as they are known, in our clinics, and that was at Brantford Urgent Care. We were going to do a pilot project with one of those, using automated dispensing, as opposed to just having our clients, patients, going to the pharmacist. We would be able to do it all right in-house, and that was the idea. At the time, there were a couple of problems with that. First of all, was that the Ontario government did not allow e-scripts. So basically, any kind of scripting that was done would have to be done with the doctor's signature and dated, and then faxed to the pharmacy, or find some other way of doing it. That posed a problem for us because, as you well know, the idea behind these automated cabinets or dispensing machines are that they should be able to produce a script, and that the patient, through a barcode system, goes over to the machine, gets the barcode scanned, and then the appropriate medication is given to them. Part of the things that interested us was there were a number of different levels that could control human error. First of all was that once it's prescribed, the machine would definitely give you the exact dosage, exact route, type that it's, if it was liquid, capsules, whatever. It would do all the interactions automatically, so if there was anything that the doctor did not think about, or whatever, just like the pharmacist, it would pick up. It was designed through certain technologies, one of them being Script Pro, I think, and Script Logic. There were two competing kinds of technologies that we could integrate into this. And that was the idea, and it was great because you could have this at a clinic level, and the patient would see the doctor would do his script, do it on the computer, the patient would walk out, go up to the machine, and get it delivered basically right there without having to leave the premises. The other good thing was, if there was any kind of interaction or additional information that the patient needed, we would have a way to integrate that into the machine with a video conferencing, or just telephone conferencing. Basically, a person on the other side, and this is obviously a trained technical person. It could have been pharmacist tech, a pharmacist themselves. If it's more medical, it could have been a nurse practitioner. It could have been anyone. We were at the beginning stages, so the possibilities were limitless, and that's what we wanted to do. We wanted to have that interaction, so that if there was a problem either with the medication being dispensed or the types of medications, if there were things that the patient needed to know, somebody would come on the screen and have a one-to-one discussion with the patient right there. So it would all be kept in-house. It was very much a technology blended in with personal service. The other side to that is that all these machines had an emergency override. So basically, if you needed to get a medication to a patient urgently, and you couldn't send the script to a pharmacist to be processed or whatever, the nurses or other medical staff, doctors, even the pharmacists, if there was one on site, would have an override code that they could open those machines up and dispense the medication appropriately in an emergency situation. The only problem with that is that the more you didn't use the machine, the chance for human error would increase again. So that was the trade-off, but you had to have something like that to be able to do it. So at the time that I was involved with that, the biggest restriction to doing it, first of all, was getting the public used to interacting with the machine. Second, and probably the worst, was being able to do it with the approval of the Ontario government, to allow us to do e-scripts and to use some of the software that was available to interact with a lot of the electronic medical records that these clinics were already using, that the databases may not have been compatible. So there was a number of things that we had to do to be able to make it so. But moving forward now, I'm no longer involved, but I see that they've actually come a long way, and that these machines are now all over hospitals and clinics, and even at pharmacies themselves. I mean, they're very easy to use, and anyone can go up to them with their script. It's all barcoded. It's very much controlled, and better than any physician, they will tell you if there is a problem with the medication being prescribed or the dosage. So it was actually a great idea, and I think it's an idea that will probably work even better as we go forward and as people get more educated on this.